My name is Stephanie Freeman. I'm the Memory Center Program Coordinator here at Norton Neuroscience Institute's Memory Center. Thanks for being with us today. This is the second presentation of our 3-week series. So this is sharing some updates in the field of dementia. There's a lot going on in movement in the field, so we're happy to have Dr. Cooper here to share some of that information with us. Our next presentation will be next month, and that will be June 11th with the Alzheimer's Association, sharing kind of the impact of Alzheimer's and related dementias and how that impacts our community. So look forward to hearing from Aaron on that. But first with us today, Norton Neuroscience Institute Memory Center loves partnering with the Alzheimer's Association on these programs. And today we have Program Manager with the Alzheimer's Association, Meredith Plant, to share some of their resources and services. So Meredith, you can go ahead and take it away.
Thank you, Stephanie. It's my pleasure to talk to you all a little bit today about our resources that we have at the Alzheimer's Association. It will be a lot of information at once. That is okay. I will make sure that Stephanie has the PDF of these slides as we move forward. And let's go to the next slide. So if you aren't familiar with the Alzheimer's Association, we are a national nonprofit, and our vision is very simple. We want to see a world without Alzheimer's and all other dementias. So with our mission, we really try to accelerate research across the globe. We're focused on driving risk reduction and promoting early detection. And then, of course, we really want to help people with care and support. And that's kind of what I'm going to talk a little bit more about today. So who are we in the Greater Kentucky and Southern Indiana chapter? I mentioned that we are a national nonprofit, but we are divided up into chapters, which makes it a little bit easier to manage and to serve constituents. So we do have 78 chapters nationwide, and we, being a nonprofit, of course, we fundraise so that we can fund research, fund these caregiver support programs, and you'll see on the slide that 78 cents of every dollar funds our mission. So, and within our chapter, we serve all of Greater Kentucky except the 3 counties that are right up by Cincinnati. Boone, Kenton, and Campbell are part of the Cincinnati chapter, and then we have part of Southern Indiana, including Evansville, Jasper, some of those areas. So we have 11 staff and 300 plus volunteers, because as you can imagine, we can't do it with just 11 staff. We're strong and mighty, but we're not that strong and mighty. So our volunteer base is really important as we provide support and education and also fundraise. The Alzheimer's Association just released our 2025 facts and figures last week, and this supplied is almost, I feel, a little overwhelming with the numbers and the data and the stats. And I kind of think it's supposed to be, because if you're dealing with this disease, it's, as a caregiver or as a person who has it, it is overwhelming. But right now, over 7 million Americans 65 and over are living with this disease. And something that often surprises people is that Alzheimer's and other dementias, it kills more than breast cancer and prostate cancer combined. So I won't go through every single statistic on this slide, but I do think one thing that I want to point out, I gave you some of the shocking statistics, but something that I think is encouraging is up to 4 in 5 Americans feel very optimistic about Alzheimer's treatments in the next decade, which I know Dr. Cooper is going to talk a little bit more about the advances there and why people are having hope. So who's impacted by this disease? It's every gender, every race. It's our aging population, but our caregivers are more and more, they're not just, retired folks caring for their very elderly parents. They're people that are still working. They're still taking care of their own children. So we call that the sandwich generation. And we're seeing a lot of people who are now even millennials taking care of their parents or grandparents who have this disease. So it's really I think people that they'll ask me, oh, well, you just talk to older folks a lot, don't you? Because it's Alzheimer's and dementia. And I said, I talk to everybody. I talk to people in the workforce. I talk to people my age, because this disease is impacting everyone. This slide just has some of the different ways that we provide care and support to those who are affected. Again, I can't go through all of them because we would be here. I would be presenting the entire time, and we need to get to Dr. Cooper, but I will highlight a couple of things. At the top of the slide, you'll see a free 24/7 helpline there. We really promote that at the Alzheimer's Association because you can call and get a care consultation. You're talking to master's level clinicians and specialists. And even as staff, I have called them and asked for advice and assistance when a caregiver I was working with felt like she couldn't call because her husband might hear her on the phone. And I said, let me call. And it was really, they walk you through everything step by step. And they also send up a nice follow up email because sometimes it can be overwhelming when you're hearing all these different advice and things that you need to do. So we highly recommend that. Also, if you want to go down a rabbit hole or a wormhole, alz.org. There is a lot of information on there about the disease, about resources. So if you're one of those that likes to kind of read up and check up on things, there's a lot on there as well. This is just one example of something that you can find on our website. We have a lot of publications that you can download that talk about, you can see here everything from financial and legal, caregiving, safety. So it's nice that it's broken up into categories there so that you can hone in on exactly what you want to read about. This also is another screenshot from our website if you want to kind of connect a little bit more with other people, learn a little bit more about memory problems and how these resources that we have might help. Again, breaking it down for you. So caregiver support. I'm sure that a lot of you all have maybe heard about support groups for caregivers. We have them across our chapter. They're led by trained Alzheimer's Association volunteers. And really what a support group is kind of what you would think. You go into a room, there's no set agenda or topic. It's everybody kind of comes in and shares maybe what's gone well that month or what's been a challenge that month. And sometimes I feel like they find solidarity and validation when they go to these support groups. If we had all the answers in the support groups, that would be wonderful. Sometimes there just aren't great answers or solutions, but people can share tips and tricks and again have a chance to just kind of share their emotions of what's going on. So I already mentioned our 24/7 helpline. And another thing that I might kind of talk about in addition to the support groups for caregivers, we do have some early stage caregiver support groups in the Louisville and Lexington areas. So something that you can learn more about on our website, reach out to me about, but those groups are for the persons in the early stages and their caregiver. And boy, do they like to do social stuff too, potlucks and going out to eat, and it all revolves around food. We've done some Super Bowl parties as well. And we do things like what I'm doing today. I'm at the Alzheimer's Association. I mentioned all those volunteers. They go out and give education programs on really a variety of topics, 10 warning signs about caregiving. And we do them both virtually and in person and on demand as well. This is another slide about some of the support groups that are in the Louisville area. We also have a virtual support group for spouses and partners. That was one of my volunteers said, I'm dealing with different things than the children are, the children, I put it in quotes, being my role has really changed as a spouse, and I'd like to talk to other people about that. So that is something that's really taken off in the past year. So this is the series that I think Stephanie was referring to, so I won't go further into that, but we will send this out via email. I'd be remiss if I didn't mention the fundraising opportunities that are out there with our Walk to End Alzheimer's and the longest day. The longest day is going to be June 20th. It's literally the longest day in our calendar year, and a lot of places take that opportunity to do a special fundraiser on that day or near that day. And of course, the Walk to End Alzheimer's, all of our walks in our chapter are in the fall, usually September, October. And we call it our largest support group because not only are people fundraising, but they're coming out and they're getting comfort and care and having fun. Quite frankly, they're fun events as they do the walk. Now, this is not a competitive 5K. All right, you can come out and hang out and walk if you want to, or not walk if you want to. It's really just a chance for us to come together and support one another. So I probably will leave questions to the end, Stephanie, if that works for you. Okay. And but I will stick
Well,
around and turn it over to you, Stephanie.
appreciate that. I always like seeing all this highlighted for our community. So thank you, Meredith.
You're
All
welcome.
right, so we will jump right into Dr. Greg Cooper, so giving us some updates in the field of dementia. So Dr. Cooper is a neurologist here at the Norton Neuroscience Institute's Memory Center, director of the Memory Center, and so we are glad he's here today to share his knowledge about all that's moving in the field. So Dr. Cooper, go ahead. And I will say, everybody, there's a chat box or a Q&A function at the bottom. If you can, please put your questions in there, and we will answer all questions at the end.
All right.
There we are.
Apologies, my computer is bouncing around on me. Does the screen look correct? Excellent. Okay. Well, thank you all for having me today. So the idea behind this talk, the central theme is updates in the field. And let's see if I can advance the slide. Excellent. So is just kind of an outline of what we're going to talk about. I'm going to give a very brief background, and then I'm going to talk about evaluation, treatment, and even prevention of dementia, and really highlight some of the updates or some of the advances we've made in the last year or recent years. So going straight into background, I still think it's useful to talk about a couple of definitions. And two broad categories are useful to keep in mind. One is mild cognitive impairment, very common condition, and it simply means there are changes in our cognition. That may be memory, it may affect our language, it may affect executive function, our ability to plan, organize, any number of things. It is more than what we could expect just for normal aging, but it is not to the degree that it really significantly impairs our day-to-day functioning. And then there is dementia. That is a more severe condition where we have impairments in cognition, and now it is affecting our day-to-day function. Now we need help with various activities like managing our finances, for example. And think of dementia as a very broad umbrella term. There can be multiple causes for dementia. Dementia is that broad overarching category. And then when we think about the major causes, there are many more than this, but these account for nearly all cases of dementia. Alzheimer's disease, that's the most common one. That's what we think about most often. With that, it's marked by impairments in memory, and in particular, short-term memory. So if I have Alzheimer's disease, I may remember things from 20 years ago as well as I ever did, but I have trouble remembering yesterday because I'm having trouble forming those new memories. So we think of Alzheimer's disease, particularly early on, as a problem with recent or short-term memory. Then there's vascular dementia, and as the name implies, it's associated with cerebrovascular disease. Now, that may be stroke, or it may just be more of a gradual process where we have changes in our vasculature, our blood supply to the brain. And while that can mimic Alzheimer's disease, we often see more of a slowing in cognition. We may get there, but the wheels are turning more slowly. We may have what's called a dysexecutive syndrome. We have more difficulty organizing, planning, managing complicated things. And then there's dementia with Lewy bodies, and that overlaps very much with Parkinson's disease. In fact, there's sort of an umbrella category for that called Lewy body disease that includes Parkinson's disease. So with that, we may see physical changes that look like Parkinson's disease. We may see a lot of fluctuations, a lot of really marked up and down. And we may early on see very prominent hallucinations, particularly visual and particularly well-formed visuals. So, for example, seeing people or animals. And then the last category, and I'll just touch on this very briefly, is frontotemporal dementia. It's a whole nother category by itself, but very often has changes either related to language or related to personality and behavior changes. So the point there is think of dementia as a broad, overarching umbrella term, and then there are many individual causes for that, Alzheimer's disease being the most common. Now, let's get really into the meat of this, and I want to talk about evaluation of memory loss, evaluation of cognitive impairment. So the current state is this, the first thing we do is sit and talk to people. This is good old-fashioned medicine. But it's important not just to talk to the individual that we're worried about, but to talk to an informant, a family member, a loved one, a spouse, a child. Uh, if I am having memory problems, as silly as it may sound for me to say this, I am often not aware of that. I don't remember what I don't remember. And so I need a family member to help describe what they've seen. When did this begin? What were the first symptoms? How did this change over time? And really, after that, after just talking to people, we probably have the answer the great majority of the time. We want to do an exam. That's usually going to be pretty normal, but we're looking for changes that might suggest stroke or vascular disease. We're looking for changes that might suggest Parkinsonism or Parkinson's disease. Then we'll want to do some type of cognitive testing, some assessment of memory and thinking. And we'll usually use different standardized measures like the MMSE, that's the Mini Mental Status Examination, or the MoCA, which stands for Montreal Cognitive Assessment. And there are others, but we'll want to at least do some type of brief cognitive testing as an extension, as part of that neurologic exam. Then we'll do some additional blood work. We're ruling out other medical issues, and the bare minimum would be looking at a vitamin B12 level. We'll often add another B vitamin called folate. And then we're looking at thyroid function. An under or overactive thyroid can cause memory problems and mimic a dementia. So we want to rule those things out. And then we want to take a picture of the brain, some type of neuroimaging. We prefer to do an MRI scan. In truth, a CAT scan very often gives us all the information we need, but we want some kind of image. And by and large, what we're doing is ruling out things like stroke or tumor or vascular disease, that sort of thing. And that, even today, still sums up the bulk of the evaluation. In some cases, we will do neuropsychological testing. This is very detailed memory and thinking testing. It can take 2 or 3 or more hours to do. Most of the time, we don't need that, but in some cases where things just aren't very clear, that can be enormously helpful. And then biomarker testing, and I'm going to talk a little bit more about that as we go along, so we'll hold on that for just right now. Now, some of the directions we're going in the future, and I won't go into detail, but these are very interesting. Both of these things are starting to take real advantage of artificial intelligence. One, not quite ready for prime time, but it's getting close, is population risk assessment using artificial intelligence. So what on earth does that mean? That means that we are working towards a time when we can use these artificial intelligence algorithms, if you will, to look into the medical record and identify people that are at high risk or may be starting to develop memory problems before we know it on the physician side, maybe even before the family has fully become aware of it. And in that way, we may be able to take a very proactive approach. And your primary care provider may be able to say, well, we see that you're at high risk. We want to do a little more testing, a little more evaluation. And in that way, get people help, get people treatment earlier than we would otherwise. And I think that's not on the distant horizon. That's coming pretty soon. And then the other are digital cognitive assessments. And so I alluded to this that when I see somebody in the clinic, I will do some type of cognitive exam, some type of memory test. And that's usually going to be a paper and pencil test that really involves my time, sitting across the room or across a table from someone. Well, there are no now digital cognitive assessments that people can do on a computer or a tablet, like an iPad, which takes a minimal amount of office staff time, but is getting increasingly good, even after a fairly short assessment, at determining if people have a condition like mild cognitive impairment or have a dementia and need further evaluation and who don't. And this may be especially valuable in a busy primary care office where somebody may have a 10-minute appointment to take care of a half a dozen other problems and they really don't have time to assess memory or cognition. This may be a way to extend that evaluation and get more people really properly evaluated. So these are two things that are either here or on the near horizon. Let me now talk a little bit about biomarkers. I know I just alluded to that briefly. Biomarkers, really, it's any kind of measure that helps us detect and follow an underlying disease. In the world of memory disorders, that these are usually proteins, and in particular abnormal proteins that we're looking for in the body in some type of fluid like blood or spinal fluid or even by a skin biopsy. Why are these useful? Well, first, they may help us confirm a diagnosis. So if I'm suspicious that someone has Alzheimer's disease, this to a very great degree may allow me to confirm or refute, rule out that diagnosis. And in time, we hope that these treatments will allow us to better track response to treatment so that we can really have a objective measure that our treatments are doing some good. And we're making some pretty good progress here. I just highlight two conditions where this has become very useful for us. In Alzheimer's disease, the proteins we're measuring are beta amyloid and tau. More about that in just a minute. In Lewy body disease, we're looking at a protein called synuclein. And believe it or not, the way we most often test this in our own clinic is through a skin biopsy, and that's been extremely useful. I won't talk more about that, but you get the point. Now, to understand Alzheimer's disease and how these biomarkers play a role, it's helpful for us to understand the prevailing idea in Alzheimer's disease, which is the amyloid hypothesis. It's been around for quite a while, and there is some debate, but this is by far the prevailing idea. And it states this: it's the deposition of beta amyloid, sometimes referred to as A beta, and a protein in the brain that is then the key trigger that leads to a whole cascade of events that ultimately leads to the symptoms we see in Alzheimer's disease. So another way of looking at that, by this hypothesis, we first have deposition of amyloid. That leads to synaptic dysfunction. That synaptic means the connections between brain cells, between nerve cells. So we those connections start breaking down. Then we see tau-mediated injury. This is another way of saying neurofibrillary tangles. Amyloid are plaques, tau is neurofibrillary tangles. Amyloid and tau are the proteins that we see in those with those pathologies. And then we start seeing atrophy, shrinkage of the brain. And then it's only at the very end of this that we start seeing cognitive decline. Let's look at this another way. Now, if you look at that top panel, that long, squiggly, sort of blue and gold line is the amyloid precursor protein. That's a protein that is normal. We have it not just in our brains, but throughout our bodies. We don't entirely know what its function is, but it has a normal role. When it is broken down by a couple of enzymes called secretases, in that bottom left panel, those scissors, think of those as secretases. These are the enzymes that break it down. It releases that little golden fragment. That's beta amyloid. Well, that's happening right now to all of us. But for most of us, that happens. We clear it out of the brain. It's not necessarily a big deal. But in some cases, we either produce too much or we're not clearing it out of the body appropriately. And then you have what we see in that bottom right-hand panel, plaques. Those little fragments start to clump together. And that's an amyloid plaque. And that, to a degree, is what we think leads to everything else we see in Alzheimer's disease. Now, some evidence for that is you see here in this graph. And let's not get too deeply involved in it, but if you look at the first sort of red curve going up, that's deposition of beta amyloid or A beta in our brains. Now, one thing I'll point out is that curve starts going up maybe 20 years before we ever have symptoms. That's the first thing that we know happens. And then next we start having this tau-mediated injury. So basically think neurofibrillary tangles. Then the green bar, we're seeing atrophy. The purple bar, that's when we're starting to have memory loss. And then the green bar is when we're really starting to have some impairments in our day-to-day activity. So the point there is you start seeing the deposition of amyloid long before you see anything else. You have that cascade, amyloid, and then tau, and then some of the clinical changes that we see. So, if assuming all of that is true, this is, well, several years ago, the NIA, National Institute on Aging, in coordination with the Alzheimer's Association, created a new framework, originally a research framework that would allow us to better diagnose Alzheimer's disease and make this, quote, a biological diagnosis. That's been updated recently, and now it's just the Alzheimer's Association criteria. But the general idea is the same. And it's something called the ATN model. A stands for amyloid, T stands for tau, and N stands for neurodegeneration. So in essence, think of an abnormal shrinkage of the brain. What's important here is that by this definition, if you have evidence of amyloid by a biomarker and you have evidence of tau by biomarker studies, then you have Alzheimer's disease. Now, there is some debate about this, and we won't go into it, but the point is the idea that with biomarkers, if we can find evidence of amyloid and tau, that allows us to confirm a diagnosis of Alzheimer's disease. Now, there are different ways to do that, and let's not worry about the details, but PET scan, I'm going to show you an example of that. Spinal fluid is what we most often do, and then we're pushing into serum, blood-based biomarkers. So this is what a PET scan looks like. And on the left, and in particular, an amyloid PET scan. This is a scan, in terms of going through it, it's much like a CAT scan with IV contrast, but the IV in this case is a nucleide tracer. This is a nuclear medicine test. The tracer binds on to amyloid in the brain and it shows up bright on these scans. So in the left panel, we would say in our speak that these are very cool colors, blues and purples around the edge of the brain. And in this other panel on the right, this is someone who has amyloid. You see hot colors, yellow, orange, and particularly red, indicating the presence of amyloid. And so then again, that is often interpreted as evidence of Alzheimer's disease. Now, what are the pros and cons of this? And this is really an evolving field, and there are people who are very strongly in favor of biomarkers, and there are people that have some concerns about them, but it's clearly an area we're moving forward in. In terms of pros, it increases the diagnostic accuracy. In an often quoted study, Marwan Saba noted that our accuracy in diagnosing Alzheimer's disease was only 77%. And so if we add biomarkers, we should be able to increase our accuracy quite a lot. That makes pretty good sense. It also facilitates research. It has been said, and I think rightly so, that a lot of our failures in research in the past have been because we included people in clinical trials who never had Alzheimer's disease. And so we weren't really testing the drugs in the right population. This should facilitate this. This should allow us to do much more accurate research studies. So that all makes pretty good sense. What are the cons? What are the criticisms of this? Well, current tests may be invasive, like a spinal fluid exam. Turns out that's not a big deal, but that does deter some people. Or they're not always well reimbursed. For instance, some of the high quality blood tests are not reimbursed by insurance. Uh, these tests can be misleading in the absence of a clear diagnosis of dementia. And in fact, there are studies that show if there is no evidence of cognitive impairment, they don't have very good predictive accuracy. One important study showed, for instance, if I have positive biomarkers, and let's assume that I don't have any cognitive impairment, my risk of actually developing a dementia may be as low as 5% or at most 42%. So it can be difficult to interpret these tests. What's our current state? Well, the current state is that spinal fluid, CSF, cerebrospinal fluid, is the gold standard. It is a procedure, it is an invasive test, but I will tell you from experience that has been a minor barrier for us. Amyloid PET scans may be comparable. I think they probably are comparable, but depending on where you live throughout the country, these can be very difficult to obtain, either the scan itself or to obtain insurance coverage for it. So that's been a major barrier for us. And then blood-based biomarkers. And I think most of us feel this is the future, but we're not quite there yet. Some of the blood biomarkers, the blood tests, are comparable to spinal fluid, just as good. But not all of them are. Some of the blood tests that are commonly done don't have very good accuracy and really probably aren't of any value. Uh, and then a couple caveats that are important to point out. The interpretation of these results really depends on what the probability is. If I were to test a group of 30-year-olds that have a low likelihood of Alzheimer's disease, the benefit of these tests is questionable. There's really not very good accuracy or predictive value. So the value of these tests depends very much on whether or not there is a good likelihood the individual has this underlying condition or they don't. And that's something the clinician has to work out. And then all of the criteria, Alzheimer's Association or international criteria, agree that this testing should not be done without clear objective evidence of cognitive impairment. All right, so let me move on and let's talk about treatment here just a little bit. And in particular, I want to talk about anti-amyloid therapy. So we've talked about the amyloid hypothesis. We've talked about the importance of amyloid. If all of that is true, it would make pretty good sense that if we could somehow affect amyloid, we should have an impact on this disease. Well, there have been a lot of different strategies. One strategy has been to try to reduce the production of beta amyloid. So you remember those little scissors that you saw that were cutting out that golden fragment, beta amyloid? What if we break those scissors? What if we block those enzymes? What if we don't produce beta amyloid in the first place? Well, that makes pretty good sense. Anti-aggregants. Okay, what if we allow the beta amyloid to be made, but we block it from clumping together? That makes good sense. Or what has actually been the most effective are immunologic strategies. And this is an idea that has now been around for over a quarter century, basically trying to use our own immune system to help attack and clear amyloid from the brain. Shouldn't that help slow down this disease? Well, all of those are good ideas, uh, but they have all failed in one way or the other. So different secretase inhibitors trying to block that production of beta amyloid. A lot of good tries, we haven't succeeded. There have been a long list of monoclonal antibodies. These are antibodies produced in the laboratory that target amyloid, remove that from the brain. Again, that makes sense, but you can see I just listed three here, but we've had a number of failures in that area. So it's been a very difficult disease. Fortunately, over the last couple of years, we've had a couple of real breakthroughs. So first was lecanemab. And you all may have heard the trade name for that as Leqembi. That is also a monoclonal antibody targeting amyloid. It removes amyloid from the brain. It received accelerated approval in January of 2023. More importantly, it received full approval from the FDA in July of 2023, and many of us started using it soon after that. We'll talk more about that. And then the next one to come along is donanemab. It's also a monoclonal antibody, an antibody that targets amyloid and removes amyloid. It was approved about a year later, July 2nd in 2024. So let's talk about those in a little bit of detail. Lecanemab, monoclonal antibody, it targets the soluble protofibrils. And there's debate how important that is. What that means is it's targeting those little golden fragments that we saw on the slide earlier when they are just starting to stick together. They haven't really formed a full-fledged plaque, but they're just starting to stick together. And there is some thought that might be the most toxic form of amyloid, so maybe that's what we ought to target. So that's lecanemab. And if you look at the effect, this is looking at amyloid PET scans and basically measuring the removal of amyloid in the brain. So if you look at that top blue bar, these are people that were given a placebo, basically like a sugar pill, if you will. And in that case, the amyloid actually went up a little bit over time, but didn't really change very much. On the other hand, if they received infusions of lecanemab, you can see that dropping very dramatically to the point that most of these folks, you would consider them amyloid negative. They had such low levels of amyloid, you would consider them not to have significant amyloid. What about clinically? What do we see? And again, just get the big picture here. This is a graph looking at something called the CDR sum of boxes. And really, that's just a measure of global functioning. And what we see is people that were on placebo, they declined, the blue bar here. People that got lecanemab, now they still continued to decline, but significantly more slowly. And if you really look at it, the whole slope of the graph has changed. So it hasn't just improved the symptoms over placebo, but it's changed the rate of progression over time. And then looking at another scale, this is an activities of daily living, ADL scale. And you see the same thing. People declined on placebo, those on lecanemab, they declined, but at a slower rate. They were able to do these activities of daily living with less assistance, better over time. So what about donanemab? Also a monoclonal antibody. In this case, it's targeting the plaque. So after they've started to clump together a little bit more and start to form plaques. And whether that distinction is important is not entirely clear. They're both targeting amyloid. But there are a couple things that are worth pointing out here. Again, I don't want to get into the details too much. But in this particular study, patients had to have scans that showed both amyloid and tau. Typically, we just do an amyloid PET scan to show there's amyloid. But in this case, they wanted to be that much more confident that there was really Alzheimer's disease pathology there. And then they took it a step further. And the reason this is important is when we interpret the results, they divided people into levels of tau. So if someone has Alzheimer's disease, you expect them to have amyloid and tau, but they looked at people that had kind of low to medium levels of tau and people that had high levels of tau. And what that is probably doing is separating people out to even milder forms of the disease, so earlier on versus later on in the disease. So we're trying to maybe differentiate those two groups of people. And then the other unique thing about this study is that after people were started on treatment, if they had a PET scan that showed that they had now cleared all their amyloid, people got off of treatment. So usually in a study, people remain on the active treatment if that's what they're assigned to the entire study. In this case, we kept measuring amyloid, and if we eventually became amyloid negative, then people were able to stop the medication. So what do we see? And what we see is similar to what we saw with lecanemab. In this case, the gray bar in both slides are people that are on placebo, and the green bar are people that were on donanemab, or Kisunla is the brand name for it. And what you see is less decline, a slowing in the rate of decline. What you also see is that if you get people with low or medium tau, people earlier on in the disease, there seemed to be a bigger difference than if you just combined everybody all together. So you can take this potentially as evidence that the earlier you start one of these medications, the more likely you are to see a bigger benefit. That to some degree, maybe this is telling us that time is brain. And looking at a couple other measures, this is looking at the CDR. That's that global measure. How am I doing overall? And again, you see a clear difference. Things are slowed down when you're on donanemab. And if you take those people with low to medium tau, again, we think very early on the disease, that difference, that benefit is even greater. Well, so all of that is good. What are the potential problems with these medications? And the risks fall into two big buckets, if you will. Infusion reactions, and these are typically things like fever or chills or muscle aches. Um, Usually something we can manage pretty easily with medications. We have learned with lecanemab that sometimes those infusions are delayed. People seem to be doing well after the infusion, and then that evening they'll have chills or shaking chills. Fortunately, that has been a relatively small problem for us. The bigger issue is something called ARIA, and that stands for amyloid-related imaging abnormalities. Big long name. What it really means is brain swelling or brain bleeding. Bleeding can take on two forms. It can be microhemorrhages, truly microscopic areas of bleeding that we're able to see on a CAT scan, or it can be macrohemorrhages, large areas of bleeding in the brain. So that's what we fear the most. And this is what it might look like on an MRI. So if you look at this top panel, just look at where those white arrows are in section B. It's a little white there. That's what some swelling looks like. Yeah, that can be bigger, but that gives you an idea. And then in panel D, where the circle is, those little black dots are microhemorrhages. Now, they're actually truly microscopic, but because of something called a blooming artifact with a specific type of MRI, those are much larger and they look like little grains of pepper. Now, in these cases, the individual probably doesn't have any symptoms at all, but it's something we need to pay attention to, and it may modify our treatment going forward. But some people can have symptoms. Symptoms like headache, confusion, vision changes, dizziness, nausea, gait impairments or ataxia, stumbling. And in some very serious cases, it can cause seizure. SE stands for status epilepticus, seizures that don't stop. Encephalopathy or stupor just are another ways of saying real confusion. Focal neurologic deficits, that's what really I should have just said stroke-like symptoms. ARIA, if it is very serious, can mimic a stroke and can trigger the need to be put in the hospital. We'll talk a little bit more about the risks of that in some of the other slides. But the take-home point there is that is probably the most feared side effect from these medications and something we have to monitor carefully. So, who would be eligible for these treatments? Well, it is people with mild cognitive impairment or mild Alzheimer's disease, but both related to Alzheimer's disease. Let me explain that a little bit better. Not everyone with mild cognitive impairment will develop clinical Alzheimer's disease, but many people with mild cognitive impairment, if we do the right testing, we can find underlying evidence for Alzheimer's disease. So, in a sense, Alzheimer's disease before it really becomes a dementia. So, those are the people that we're looking for, people with very early, very mild disease. The mini mental state exam is a test that we often use, and criteria might say a score of 22 or above would qualify you for lecanemab. 20 and above would qualify you for donanemab. Once we get below 20, then unfortunately we think the underlying disease has progressed too far for these medications to be helpful. Pretty wide age range right now that's recommended from 50 to 90. If someone really has this condition younger than 50, fortunately, while that's quite rare, we might consider treating. And then the presence of amyloid. I know this sounds silly every time I say it, but there's no reason to start a medication to remove something that is not there in the first place. We need to know there's evidence of amyloid. We want to be confident that underlying Alzheimer's disease is the correct diagnosis. Things that would exclude someone, well, inability to have an MRI. We have to do MRIs before and during treatment to monitor very carefully for that ARIA, swelling or bleeding. Evidence of a condition called cerebral amyloid angiopathy. It's a related condition, maybe more of a vascular condition, where amyloid is deposited in the blood vessels in our brain and predisposes us to bleeding. Well, if we have already a predisposition to bleeding, we wouldn't want to start a medication that raises that risk of bleeding anymore, even more. So we can pick that up oftentimes on an MRI. And then the other are related to vascular disease. If I have multiple lacunar strokes, these are very tiny strokes in the brain, or if I have a stroke that's involving a large vascular territory, or if I just have severe evidence of severe underlying vascular disease. And two reasons there. That tells us that Alzheimer's disease may not really be the cause of our memory loss, but it also tells us we might be at a much higher risk for side effects. So we would exclude those folks. And then a number of others, being on a very strong blood thinner like Coumadin or Eliquis or Xarelto. Again, we're very worried about anything that would increase our risk of bleeding. Recent strokes, certain immune conditions, history of seizures, that's questionable. And in our case, we usually just look if that's been a recent seizure, any unstable medical condition. And then how do these medicines actually work? So I think in many ways, there are more similarities than differences. Both of these medications are infusions. They're medicines that have to be given through an IV. Lecanemab is given every 2 weeks. It's a 1 hour infusion. Donanemab is given every 4 weeks. It's a 3 hour infusion. And then there are variable periods where we observe people afterwards, monitoring carefully for any kind of infusion reaction. We also have to do a lot of MRIs. So in the case of lecanemab, if everything goes perfectly, we do MRIs before the 5th, 7th, 14th infusion. That equates roughly to 3 months, 4 months, and 6 months. With donanemab, it's slightly more. It would be the equivalent of 2, 3, 4, and 6 months. If we see evidence of swelling or bleeding, even if it's not causing any symptoms, that will trigger us to do even more MRI monitoring, and that may even impact whether we continue the medication or not. Now, if we find evidence of swelling or bleeding on the MRI, but the individual receiving the medication is doing well, we may be able to continue the medication and just monitor carefully. But if we really see more severe signs on the MRI, or the individual is really having symptoms related to that, then we're absolutely going to stop the treatment. We may restart it later, but we're going to at least stop it temporarily and monitor that very carefully. If someone were to have very severe ARIA, certainly we'd stop the medication and we'd have to evaluate them and likely admit them to the hospital and probably start them on steroids. The ARIA may to some degree be an immune reaction, and steroids can help dampen that down. So, how do we compare these two medications? And the truth is, it's difficult to compare them directly. The studies that showed they're effective didn't compare one to the other. They compared the medication to not taking the medication. So it's hard to compare them directly, but there are some ways we can do that. Both studies looked at this global measure, the CDR sum of boxes, and both showed pretty comparable results. Lecanemab slowed things down by about 27%, donanemab by about 29%. And what we usually tell people, there are a number of measures that were done which might show slowing ranging from as little as 23% up to 36%. The general line we tell people is both of these medications slow the progression of conditions like this by about 30%. And it's very difficult to say that one is clearly better than the other one. What about ARIA? That's the side effect that we really worry about. Well, any ARIA, any swelling or bleeding that we might pick up on an MRI, whether a person has symptoms or not, we see that in just over a fifth of people on lecanemab and a little over a third of people on donanemab. If we look at people that have symptoms related to that, symptoms like headache or nausea, vision changes, confusion, and that's what I think I pay most attention to. What's the likelihood of having symptoms related to that? It's about 3% with lecanemab, about 6% with donanemab. Now, we can break that down even further, and as one measure that we virtually always do if we're considering these medications is check an additional blood test. It's a genetic test looking at an ApoE gene. We all have the ApoE gene. We all have two copies of it. What we're interested in is, do we have 0, 1, or 2 copies of the E4 allele? So in this case, I could have made this clear. Non-carrier means I don't have any copies of the E4 allele. Heterozygous means I have one copy of the E4. Homozygous means I have 2 copies. And what you can immediately see is the more copies of the E4 allele, the more my risk is of developing ARIA, in this case ARIA-E, but really any swelling or bleeding related to this medication. And if we just want to look at well, I'll just let you read that for yourselves, but in this case, if we look at 2 copies, about a third of people with lecanemab will have signs on an MRI, and about 9% have symptoms. In donanemab, it's about 40% of people that have some sign on the MRI. We don't have what that absolute number is for symptomatic. In terms of administration, and they're both infusions. Lecanemab's every 2 weeks, donanemab's every 4 weeks. How long do you treat? And that's to some degree an unanswered question right now. With lecanemab, the current thinking is indefinite, but after 18 months, we'll transition to a maintenance dose where instead of once a month treatment, it's every 4 weeks. And before the FDA right now is a subcutaneous dosing version where you could give yourself a shot at home. There have been questions. Is it until somebody transitions to the moderate stage? Maybe, we don't know. Is it possible that we could look and see if people are amyloid negative and stop the medication? Maybe, but the truth is we don't know. With donanemab, a similar story. There is no definite time limit to this, but certainly based on their studies, it would be reasonable after a period of 12 or 18 or 24 months to try to obtain a PET scan. And if a person is amyloid negative at that point, perhaps we could stop the medication. Their studies certainly support that idea. And this is, I think, what things look like in terms of treatment. If we look at that dotted blue line, this is what treatment looked like 25 years ago. And then we introduced medicines like donepezil or Aricept, rivastigmine, Exelon, galantamine, Razidine, and we pushed that line over. People had a slower decline, if you will. They held on to some of their abilities better, longer. When we added memantine, we pushed that line even over a little bit further. And now, when we add medicines like lecanemab or donanemab, we're pushing that line even more. Where now we're actually bending the slope of that curve. We're bending the curve, trying to turn this into a more manageable chronic disease than it has been in the past. All right, now I'm going to really change directions here. And the last little bit is going to talk about some updates in prevention. So I'll start with a quote. While we are making great strides in our scientific understanding of dementia, early diagnosis, better treatment, the most effective treatment is still prevention. If we can stop this disease before it ever really takes hold, that's going to be our best bet. To that end, a recent update of the Lancet Commission report last year in 2024 indicated that approximately 45% of dementia worldwide, and that includes in the US, is preventable. And that number seems to hold up again in the US. They keep expanding the number of modifiable risk factors, and now we're up to 14 risk factors. And these have been divided, I'll show you in the next slide, into early life, midlife, and late life. And one point I would want to draw out here is it is probably never too late to pay attention to some of these risk factors. So even if I am in mid or later midlife, I may still be able to do things that address that low education level. Maybe I can continue to do things that are cognitively stimulating. I can continue to pursue education, and those may build up my cognitive reserve or even resilience. So, if we could do a better job at controlling some of these risk factors, we should be able to lower our risk of cognitive decline and dementia in the future. So, do we have evidence in life that this really can happen? And so I would point out the fingers model. Now, this was developed from a Finnish geriatric study, took place in Scandinavia. And they looked at 5 elements, so the 5 fingers, if you will. Looked at healthy food, so diet. We'll talk a little bit about that. Physical activity, so regular exercise. Mental stimulation, I would say cognitive exercise. Social activities, avoiding social isolation, but really engaging socially. And then paying attention to our cardiovascular risk factors, keeping an eye on things like high blood pressure, diabetes, cholesterol, etc. So their model was to address very intentionally all of these risk factors with the hope of lowering risk of cognitive decline in the future. And I would tell you, if you looked at their original study carefully, they were not necessarily looking at people that were perfectly healthy in midlife. They were looking at people who arguably were already starting to develop some cognitive decline, uh, meaning that any result they saw, in my mind, is really very impressive. And they did see impressive results. They showed a 30% reduction in the risk of cognitive impairment overall, which is really quite impressive. But then if you look into this kind of yellowish panel, I saw some really impressive results, I think. Overall cognition actually improved by 25%. Executive function, that's our ability to plan, to organize, to manage our affairs, improved by 83%. Complex mental memory tasks, 40%. Processing speed, our agility, our mental agility, if you will, improved by 150%. So really putting these lifestyle strategies into action led to significant improvements and to a reduction in our risk of cognitive impairment. So the next obvious step is how can we move this into practice worldwide. And so the group that developed the fingers model has now developed the Worldwide Fingers program, WW Fingers. And their goal is now to extend this research and extend this practice worldwide, looking again at controlling cardiovascular risk factors, physical exercise, mental stimulation, social engagement, and diet. And I'm really very proud to say about a year ago, we were welcomed into the fold as a member of this Worldwide Fingers program. And we really hope to bring that to practice here in our region. Let me say a little bit about diet, which is really an important part of this whole lifestyle strategy. And there are two diets I'm going to talk about. I'll mention first the Mediterranean diet. Uh, Long been known to have a lot of benefits. It's associated with longer survival overall. It's associated with a reduction in our risk of cardiovascular disease. It's associated with a reduction in our risk or incidence of cancer. But more recently, and now this is a few years, it's been shown to have associate with a lower risk of global cognitive decline, but also a lower risk of Alzheimer's disease. So there's a lot of good associated with the Mediterranean diet. What is the Mediterranean diet? Well, it's a largely plant-based diet, really focusing on fruits, vegetables, whole grains, legumes, and nuts, replacing butter with olive oil or canola oil, vegetable oils, limiting red meat to a few times per month, and really focusing on fish and poultry at least a couple times a week. Well, that is without a doubt a good diet. I will admit, for me, it's always been a little vague for me. I need something a little more concrete. And so I'm a real fan of the MIND diet, which stands for Mediterranean Dash Diet Intervention for Neurodegenerative Delay. So Mediterranean, it's obviously overlapping heavily or drawing from the Mediterranean diet. The DASH diet is a diet that was developed specifically for hypertension. It was developed by Dr. Martha Morris at Rush University. And at least in one of her studies, and there have been different studies showing variable results, but one of the studies showed a whopping 53% reduction in Alzheimer's disease risk when this diet was followed rigorously. When it was followed just moderately well, which I think is probably more what most of us are capable of, still saw a 35% reduction in risk, which I think is very significant. One of the reasons I like it is more prescriptive. It lists a number of items that are good and how much we should get. So, as an example, leafy green vegetables, we should get at least 6 servings a week, maybe one a day. Other vegetables, at least one a day. And you can read the list as it goes on, but it tells you how much you should strive for these individual food categories. And likewise, it tells you categories that you should avoid. It doesn't tell you you can't have them, but tells you how much you should avoid them, like red meat, butter, cheese, pastries, and sweets. It's always reassuring to me that I can have some of those, fried and fast food. So if we follow that pretty well, we should see a reduction in our risk. Now, to me, it's helpful to think about why do these things work? What's going on here? And there may be a few ways that these lifestyle strategies help us. One is simply through the vascular hypothesis. What's good for the heart is good for the brain. And that's probably true. So if we are improving our vascular health, we're improving our heart health, we're reducing our risk of stroke, but we're also probably protecting that blood supply to the brain, which in turn protects our brain, keeps our brain healthy. So that makes pretty good sense. The stress hypothesis. Stress can damage the brain. We have a pretty good idea of that. We also know that stress is just a fact of life. But if we have more robust social networks, we're avoiding isolation. I don't think this necessarily means we're going to large public events every day, but if we have a good social network, we are not isolated. That seems to mitigate the effect of stress on the brain. So yeah, stress is still a part of life, but if we're mitigating that effect on the brain, we're protecting the brain and we're preventing cognitive decline. So that makes pretty good sense to me. And then arguably as important, if not more important than all of them, is the idea of the cognitive reserve hypothesis. Now, originally, this was taken to mean that people that had a rich early life as a child, high levels of education, things early in life, that we built up cognitive reserve that then protected us in later life. And that's almost certainly true. The problem with that is it suggests that once you've left early life, too bad, it's too late now. And that turns out to clearly not be true. That through enriched activities, social activities, cultural activities, cognitive activities, all of those things help build reserve in our own brains. Probably what they're doing is increasing the number of synapses, connections between our brain cells that are helping protect us against the effects of these other things that are trying to tear us down cognitively. And we can do that throughout our entire life. So it's never too late to build up cognitive reserve. I think that, again, that ties probably both into mental exercise and social activity. So let's try to boil this down. What can we do to keep our brain healthy? Well, some just good general health recommendations. Treat diabetes if you have it. Treat high blood pressure if you have it. Don't smoke. Watch your weight. I feel silly saying this, but it's absolutely true. Avoid head injury. If you ride a bike, wear a helmet. If you're driving a car, wear your seatbelt. And limit alcohol. There's some debate over this. Some people would argue the only safe amount of alcohol is no alcohol. And there are other people with real evidence to support them that would say, well, alcohol in moderation is at least neutral, may even be slightly helpful. But do we really mean moderation? For women, that's maybe half to one drink per day, one small glass of wine. For men, that may be one small glass of wine, one beer, one mixed drink. But the key there is moderation. And then let's really pay attention to other lifestyle strategies. Getting regular mental exercise. It doesn't matter what that is, the details don't matter, just do something. Physical exercise. Ideally, some cardiovascular exercise, something to get your heart rate up, get you a little short of breath, but maybe also exercises that are toning, help keep that muscle mass up. And then regular social contact, maintaining adequate sleep, targeting 7 or more hours a night, and then really paying attention to your diet. And the two best diets in my mind are the Mediterranean diet and the Mind diet. Either of those really, I think we have a lot of evidence can help lower our risk of problems in the future. And with that, that is telling me that I have reached the end. So thank you guys very much for your time, and I am happy to answer any questions that might come up.
I feel like this is a lot more movement this year than the last couple of years in terms of new strategies, new approaches, things of that nature. So, and you've been a big part of that. So thank you for all your work.
It's
lots to keep up with.
That's an increasingly exciting time. We need more movement.
Yeah, we do. We'll go ahead and get to some questions. We had a couple pop in. I'm going to go to Donna real quick. I don't know, Donna, if you're, I will see if I can allow you to talk. She's had her hand raised. Let's see. Donna, are you able to ask your question?
I think you'll have to come off mute.
Nope. Okay. So if she hops on, I'll let you know. So one question did come in. If you could expand a little bit more or just give a definition again on what is donepezil and memetina and what do they treat?
Very good. So donepezil it's the long name for it is, we'll get to you in a second, Donna, I promise. The long name is cholinesterase inhibitor. And that name isn't important. What it means is it blocks the breakdown of a neurotransmitter, a chemical that's normally in the brain called acetylcholine. So donepezil, the trade name is Aricept, and there are two others in that class, rivastigmine, trade name is Exelon, galantamine, the trade name is Razidine. All three of those medicines work in the same way by blocking the breakdown of that neurotransmitter. So we have higher levels of that neurotransmitter in the brain, and that helps facilitate the connection, the communication between brain cells. And in that way, kind of broadly speaking, in general, helps improve our cognition. Now, memantine is a little bit a little bit similar. Memantine, the trade name for it is Namenda. It works in a different system in the brain that uses a transmitter called glutamate. And it's not exactly affecting the breakdown of glutamate, but it's facilitating those neurons, those brain cells that communicate by glutamate. So it's also trying to improve communication by brain cells, just doing it in a different system in the brain. So coming at it from a different angle. So all of these medications, think of them as cognitive enhancers. They help with memory and thinking in general. Donepezil, Aricept, that group does it from one direction, acetylcholine. Memantine or Namenda, it does it from a different direction, glutamate. So hopefully that made sense.
Awesome. All right, Donna, let's ask your question. Go right ahead.
I'm afraid I'm still not hearing you, Donna.
Oh,
Sorry.
yeah, we're not hearing you, Donna. Go ahead and put your question in the Q&A and we'll make sure to get to you. Thanks for your patience on that. Regarding the new drugs, so lecanemab, donanemab, I'm assuming, can any physician anywhere prescribe these?
So technically, yes. Practically, probably not. And the reason is these are really complicated medications to use. And I can tell you an enormous amount of work by people other than me have gone into us and other places being able to do it. So it's a limiting factor. Technically, it's a prescription medication. Anyone with a license should be able to prescribe it. But because of all the steps that are involved in terms of the monitoring, in terms of coordinating with an infusion center, all of that, it's probably going to be, at least for the time being, limited to individual centers around the country. I hope that improves over time, but it's a little bit limited now.
All right. Can prevention strategies help if you have a diagnosis of dementia?
So that is a great question. My opinion, and this is my opinion based on only a small amount of science, is probably yes. We don't entirely know that yet. There has been one small study, very small study, that indicated that it could help. That was such a small study that we probably can't draw any firm conclusions from it yet. I can at least say these same lifestyle interventions are not going to hurt anything, and at least I have a belief that they might help. So that's a little fuzzy, I know.
Could you speak to delirium? What is delirium?
Delirium. So delirium essentially means this is not a very scientific or medical definition. I would say very broadly, it just means the brain is not working well. And that is usually because of something else. So if I go into the hospital and have a pneumonia or a urinary tract infection or any other type of infection, or if I've gone through surgery, or sometimes just because I'm in the hospital and we don't know why, that can trigger a delirium. And it is just a very broad condition where the brain overall is not working well and it causes us to be confused. And it can cause us to appear very sleepy and just out of it. It can cause us to be very agitated or hyperactive. Oftentimes, we're fluctuating between those two things. We're ping-ponging back and forth. It can cause us to hallucinate, to see people that aren't there, to see things that aren't there. But it's usually something that happens because of some other medical factor. Fortunately, it often recovers over a period of days, but it can take weeks or months to recover from that. It can be a very slow process.
Thank you. How do you monitor the stage of Alzheimer's disease?
Really, in two broad ways. I would argue the most important is by history, what people are telling me, what an individual's loved ones or family members are telling me. And based on that description, we will largely think of this as mild, moderate, or severe. But we also include into that an examination. And so, just as an example, we'll do a mini mental state examination, let's say. And based on the score there, we might say, okay, 20 and above is mild, 10 to 20 is moderate, below 10 is severe. Those are really broad categories. And in practice, we don't tend to put too sharp a definition there. But I think by and large, the history, what people are observing at home, which is most important, but then second most important, what we see on our exam.
And I think Meredith, that you can attest to this too. The Alzheimer's Association and I know we have some videos online too that are very specific in terms of stages and understanding for you as a care partner what those stages look like, and more importantly, what those needs might be and what resources can maybe match that, especially when it comes to communication. I think learning new ways to be creative in your communication style. And so the Alzheimer's Association website, and then I think a link I put in earlier to some of our videos, some of our past programs like this, where we talk about stages, and it can really help you understand what those stages look like.
Yeah, there's publications on that alz.org that goes through all of that and also under a caregiving tab. So yeah.
Perfect. Let's see here. The new medications, the MABs, have they been used in any prevention studies?
Great question. They are being studied in various prevention studies right now. So we hope to have answers on that in the hopefully not too distant future. So we don't know yet. I am hopeful that they're going to show that they can actually prevent clinical disease, but we just don't know.
Great. We might need a little bit more information on this question, but just to your best ability, should incontinence or UTI be treated? I'm assuming in patients.
Yes. So good question. I would say almost always yes. And I would also say be a little cautious with what I say here. I'm a neurologist, so I'm good from the neck up, not so good here. The reason I say that is if somebody has a true urinary tract infection, that can lead to a more serious infection. It can cause symptoms. Absolutely, that should be treated. The caveat there is there are some people where you would say they're colonized. They may have bacteria in their bladder, but it's not really causing an active pathologic infection. And so a good primary care physician, internist might tell you, no, in that case, it shouldn't be treated. There's a little bit of nuance there, but typically, if we really are worried about infection, I would want that treated. Incontinence is tough. If there's a clearly identifiable cause of incontinence that we can treat, absolutely, I would want to treat that. The problem is it often can't be treated effectively. And in that case, you just want to do your best to keep people clean and dry, essentially. So you're just trying to manage the problem the best you can. Again, that's something either a primary care provider or a urologist, not neuro, but urologist, might be able to help answer that question.
Right. And Meredith, feel free to jump in if you ever have any feedback or input. So my mother-in-law is 90. She has not been diagnosed with anything. Doctor is saying she has dementia. She had a stroke 2 years ago. There's a lot of hallucinations and lots of short-term memory going on, and she will not get tested for Alzheimer's or dementia. Do you have any suggestions that might help to see what stage she might be in?
Um,
So just your input on that, aside from, the resources we mentioned online that'll help you kind of maybe identify some staging. But second opinion, would you go for a second opinion, or what does that look
I,
like?
so that is, in my opinion, that's a tough one. I would at least push to uh, if you have a good relationship with your primary care provider, push for an evaluation there, and at the very least, make sure that we're ruling out any other treatable condition. Make sure they don't have a thyroid problem. Make sure they don't have a vitamin deficiency. Make sure they don't have some other unrecognized medical problem. That's probably the most important thing. Now, I could argue if it's a good primary care provider, having an exact diagnosis matters less than just trying to help treat or manage this problem. And if a primary care provider is comfortable saying, so this is a dementia, I may not know the exact cause of it, but I see evidence for dementia and we can treat it with X, Y, or Z, then that's a step forward. Alternatively, if they're not comfortable with that but have a good relationship, they may at least be able to say, listen, just go see a specialist once. I just need some help myself as the provider. Uh, Go once to maybe get some input, get some advice there. And I think that may be another mechanism to do it. The important thing is try to get some help with this, whether it's the primary care provider or not. It's a difficult thing to go through alone. If all of that breaks down and all of that fails and I can't make any progress there, I hope you don't mind me saying this, Meredith. My next step would be we'll at least get in touch with the Alzheimer's Association. Maybe that's another less threatening avenue to at least get the information that you need. I think that's a fair statement to make.
Yeah, I was going to say, if there's a caregiver support group nearby, go and see what tips and tricks other caregivers can share, because I've heard that concern a lot when I've sat in on support groups. If there's not one close to you, obviously, again, I'm going to plug that 1-800 number, the 24/7 helpline, to talk through it with a care consult. Yeah.
Awesome. Last two questions. Any information on how being put to sleep or under anesthesia for surgery affects the rate of Alzheimer's or other dementias?
That's a tough one. There and actually there's data all over the map. I think most people would agree it is a risk. It is a risk factor. And as a neurologist, I would prefer as little anesthesia as possible for as short a time as possible. Sometimes you need anesthesia. If you need to treat something, treat it. But particularly if I already have cognitive impairment, I'm going to share that information with the anesthesiologist so that they can try to manage the anesthesia. If they can do local nerve blocks, all the better. If they can avoid general anesthesia, all the better. And if they can try to limit the time, all the better. Sometimes you can't avoid it. And maybe on a more optimistic note, I would tell you, yes, it's a risk factor, and we see people have trouble after anesthesia. We see a lot of people that sail through it and don't have any problem. So it is a risk factor, and we want to limit that risk, but don't automatically assume that it's always going to lead to bad things.
Violence. Is violence in association with delirium very common, but also maybe have a little statement in there about dementia too?
It, I would say, at least it's not uncommon, and that there's a wide range there. So especially with delirium, people are confused, they're agitated, they're anxious, and you're going to see a lot there, and that can range from just fidgeting to being more restless to truly striking out. You can see the same thing, maybe not to as great an extent, but certainly you can see that in all forms of dementia as well. So it is not uncommon. There are medications that we can use to help with that. They're of limited benefit, and we'd always prefer to limit our medications if we can. That's a situation where I would really encourage you to look for resources like the Alzheimer's Association, to learn how to manage a person's environment, to manage how we approach them, that can kind of diffuse those situations. A lot of times, through absolutely no fault of my own, I might approach somebody in the wrong way and really trigger a reaction. If I can learn from that and if I can do a little bit better job, I might be able to avoid some of those violent outbursts before they ever start.
And again, just to emphasize what you said, look for resources. If there is a dangerous situation, obviously never hesitate to call 911 and just explain the situation.
Yeah.
Most times it's handled very well and the patient can get the help they need and you can get the help you need. But also the Alzheimer's Association, or we're happy to be a resource too, to make sure we're equipping you with as much support as possible if you're in a situation like that. Is there a test? Sorry, I know I said last two, but this is a good question. Is there a test for CTE? And if you can explain what that is.
So it's a great question. I'm not going to have a good answer. So CTE stands for chronic traumatic encephalopathy. Been around forever, but it's really gotten attention as we started to pay attention to concussions and particularly, for instance, with the NFL. Uh, right now, it is primarily a pathological diagnosis, meaning we make that diagnosis after someone passes. We're They're just starting to come up with clinical criteria to diagnose this, and there is not, to my knowledge, a good, reliable test for it. It is interesting. It seems, this is based on a little bit of limited knowledge myself, that it may present early on uh, very much as emotional. It may look more like psychiatric disease. It may present later on, and it may look a lot like Alzheimer's disease. Why it might show up in two different forms, where some people might get it younger, some might get it older, we don't know. And we don't know why most people with concussion will never develop this, but some will. Um, so there's just a lot we don't know. So I'm sorry I don't have a better answer. It's a great question, and I hope in coming years we will know a little more about that.
Awesome. Meredith, any final words or statements from you?
I just, again, after the question that was asking about, violent outbursts and everything, I just want to emphasize the 1-800 number again. I know I've said it 5 times. That was actually the issue that I called about. And they were able to kind of walk me through some solutions, some tips that I could provide to that caregiver. And they followed up with an email with some stuff. So, there you can call with general questions or when you have a crisis or anything. So just wanted to reiterate that, Stephanie.
Great. Appreciate you all being on here today and sharing all this information and resources. So we will see everyone back at our next program. Hopefully we'll see you again on June 11th and understanding what the impact of Alzheimer's is in our community. I'm excited to hear about some of that, really kind of our local area and what that means for us and statistics. So thank you all again for being here. This is recorded, so you'll get a link after today's email or with an email on how you can find some of these resources and PowerPoints. So thank you all for being here today.
Thank you all.